Sumanji, it is streaming. Just to give me 1 more minute so that. Yeah, we are online.
Good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is recurrent urinary tract infection. And our guest speaker is Dr. Meera Raghavan, madam. It's my pleasure to introduce ma'am, although madam doesn't need any introduction, just I'm briefing few of it. Madam is currently senior consultant urogynecologist and robotic surgeon at Apollo Hospitals, Chennai, and major achievements including consultant in obstetrics and gynae at a leading university teaching hospital in South Manchester, UK for 5 years. Madam is a senior consultant at Apollo Chennai since 2012, MRCOG trainer and examiner, core faculty at Gibbs and Urogyne subcommittee at Foxy, faculty at Ethicon. Madam is the organizing chairperson for Fevicon 2019 Chennai. And Madam is the fellow of Royal Society, Royal College of Obstetrics and Gynecology, UK. She is the executive committee at Gibbs and executive committee member of ATN RCOG. Madam is the organizing committee member of AICC and RCOG 2020, and active member of ICS, IUGA, INS, UPIA, and SAFUG, IAG, and many more. And apart from that, Madam has many awards to her credit. Best resident in obstetrics and gynecology in 1999 from PGIMER Chandigarh. And Madam is the winner of prestigious Johnston Gold Medal in Madras Medical College for the best outstanding student in undergraduate course. And she is the winner of 32 gold medals. And apart from that, Madam has many publications to many international and national journals as well. And she has some literature in the newspaper and magazines too. So with the short introduction, I request Madam to please take over the session, and I request all the participants for their active participation, as it's a very emerging topic, recurrent UTI. And with the short introduction, I will hand over the session to you, ma'am. So thank you, Madam.
Thank you very much. Thank you for the kind introduction. I will straight away start sharing my screen. So, management of recurrent UTI from a urogyne perspective. We get these referrals regularly. When do we call it recurrent UTI? What are we supposed to look into if we are a gynecologist or a urogynecologist? Do we just treat the UTI or look for any underlying causes? Is there something we can do to prevent these recurrences? What all we need to do from that point of view is the scope of this whole presentation. So as I mentioned, we will be going through what is recurrent UTI, what is the difference between uncomplicated and complicated UTI, what do we mean by asymptomatic bacteriuria, because this poses a challenge for multi-drug resistance bacteria emanating because of injudicious use of antibiotics for treatment of asymptomatic bacteria, which is otherwise considered to be UTI, which is what we're going to clarify in this presentation. Who are at risk for these recurrent UTI? When do you actually consider this as recurrence and treated? What are the important treatment aspects, prevention methods, and advances in management? Recurrent UTI is a highly prevalent, costly, and burdensome condition. It affects women of all ages and races. Approximately 60% of women will experience sometime in their lifetime symptomatic acute bacterial cystitis. Nearly about 1/4 of patients to nearly 2/5 of patients can have a recurrence of similar episode. Of these 1/4, nearly 25 to 50% can have multiple recurrent episodes. When do we call somebody having acute bacterial cystitis? Cystitis, unfortunately, it is not a sonological diagnosis. We all do get reports from radiologists and sonologists when a woman is subjected to a scan. Debris seen, floaters seen, bladder, suggestive of acute cystitis, clinically correlate. That doesn't mean anything. Always ask for the patient's symptomatology of urgency, frequency, dysuria, or hematuria. Any new or worsening incontinence, pain in the lower abdomen, low-grade fever, if at all present. This constitutes acute bacterial cystitis, not because somebody has mentioned in the sonological diagnosis. When is the patient said to have an uncomplicated UTI? An infection of the urinary tract in an otherwise healthy patient who doesn't have any anatomically or functionally abnormal urinary tract and no other risk factors for susceptibility to UTI. Higher risk for development of a UTI and potentially decrease the efficacy of therapy. Such factors include any anatomic or functional abnormality. For example, presence of a calculus, presence of a diverticulum in the bladder, a neurogenic bladder, or a patient who's immunocompromised, or the presence of multi-drug resistant bacteria. When do we call somebody having complicated UTI? An infection in a patient in which one or more complicating factors may put her at a higher risk of development of UTI and potentially decrease efficacy of therapy. These are the characteristics of such patients. When do we call somebody is having recurrent UTI? Two separate culture-proven episodes of acute bacterial cystitis and associated symptoms within 6 months, or 3 episodes within 1 year. So this can be either due to a relapse or a reinfection. Recurrent UTI occur due to either reinfection or a persistence. What do we mean by persistence? Persistence involves the same bacteria not being eradicated in the urine 2 weeks after sensitivity-associated treatment, not just empirical treatment. Say, for example, I have a patient who is 65-year-old, comes in with diabetes and E. coli, being treated with Norflox. She has culture-proven treatment, say Norflox. Sometimes quinolones do not do the needful because it just acts like a bacteriostatic. Subsequently, what happens 2 weeks later, if we were to repeat symptoms because of repeat the culture because the patient says she has persistence of symptoms, then if you check, it is the same E. coli because it is not being eradicated for much weaker antibiotic presence. Reinfection means there is a recurrence with a different organism, the same organism in more than 2 weeks, or in between you have had a sterile culture. This also happens in diabetic or patients with cystocele and inability to empty the bladder, where you say I treat with E. coli-related antibiotic. 4 weeks later, they have a culture negative. Again, 6 weeks later, they come back with a new infection. That is called a reinfection. When do you call somebody having asymptomatic bacteriuria? When there is presence of bacteria in the urine, but that is not causing any illness or symptoms. So that is why any magnitude of bacteriuria in the absence of symptoms is called asymptomatic bacteriuria. Patients initially treated for uncomplicated bacterial cystitis who recur rapidly after symptom resolution and display bacterial persistence without symptom resolution may be reclassified as complicated UTI. They might not be recurrent UTI. The first diagnosis itself has to be rethought, and we need to do imaging, cystoscopy, or further investigation for somewhere where there can be bacterial reservoirs. As a urogyne, I generally examine the vulva and vagina for any atrophic vaginitis features because estrogen is a defense mechanism for the vaginal epithelium, maintaining the pH and thereby prevents adherence of the bacteria to the urinary cells. When that is lost due to whether early menopause, radiation, or long-standing menopausal atrophy, these patients will be prone. Second thing I look for is whether they have fecal contamination, elderly patients on a diaper, or patients who are Parkinson's, post-stroke, dementia, Alzheimer's, can have difficulty in wiping themselves clean or cleaning themselves, can have cross-contamination from the bowel orifices to the vagina and the urothelium, thereby predisposing them to becoming a bacterial reservoir and persistence of infection and have complicated UTI. Third, Young children, again because of immaturity of the vaginal tract and non-estrogenized epithelium or cross-contamination because of their ablution practices, may have cross-contamination. Patients with fecal incontinence post-delivery or patients with fistulas due to perianal abscesses of fistula can be predisposed to recurrent UTI because of this particular condition. So as a urogyne, I look thoroughly at their gait, abdominal examination, the vaginal examination, external genitalia, the proximity of the fecal area to the genitalia, whether there is a proper pudendum and a perineum length at least 2.5 centimeters, or is there is a cross-contamination, any fecal incontinence, vaginal epithelium and the health of the vaginal epithelium, urethral caliber, as well as presence of any rectocele or cystocele. So the Geriatric Societies and the Infectious Disease Society of America agree that evaluation and treatment for suspected UTI should be only reserved for acute onset of dysuria or fever in association with other specific UTI-associated symptoms, primarily include gross hematuria, new or significantly worsening urinary urgency, frequency, and or incontinence, and suprapubic pain. In the absence of these, we should not be treating unnecessarily all patients with treatment of antibiotics. This is a classical example in postmenopausal women where they complain of dysuria alone or frequency alone. That could be because of senile vaginitis and due to postmenopausal atrophy. If you treat them with antibiotics repeatedly, they are at risk of MDR, that is multi-drug resistant bacteria, and the symptoms are not going to get better, whereas a topical estrogen therapy will make them tons better. So clinicians should obtain a complete patient history and perform a pelvic examination in women presenting with recurrent UTIs. Detailed history. This is what is very, very important as a gynecologist and as a gynecologist. Whether there is any presence of gas bubbles in the urine. This is classical of patients with recent catheterization or patients with gas-forming bacteria. Klebsiella can do this. It's called emphysematous cystitis. Can be very dangerous and can cause ascending infection quickly. Diabetic patients can be prone for this problem. Hematuria, fecaluria. If there is a pneumaturia and fecaluria, always suspect colovesical fistula, especially in patients who have had extensive colonic surgery or patients with radiation to the pelvis. Cancer patients presenting very late down the lane can all be aware of these symptoms to be a pointer to a colovesical fistula. Presence of bowel symptoms, as I said, fecal incontinence, fecal urgency can be the reason why cross-contamination can happen. Any recent use of antibiotics, classical example in women who are prone for fungal infections down there are patients who have used broad-spectrum antibiotics such as azithromycin, amoxicillin, augmentin. Reason for that, these broad-spectrum antibiotics actually cull the friendly bacteria or the lactose fermenters as well in the vagina, abolishing the normal healthy flora of the vagina, thereby giving chance for the overgrowth of the unfriendly bacteria such as E. coli, which is normally present in that area. So always ask for recent use of broad spectrum antibiotics. Vaginal discharge, that is usually because of candidiasis or bacterial vaginosis. Sexual practices, use of spermicides, oral sex, and multiple partners could be pointed towards sexually transmitted infection. Diabetes in the spouse because of candidiuria or because of the high hyper content of sugar can lead to this. Vaginal cleaning practices, excessive vaginal washing, again does the same thing of eradicating the normal vaginal flora, thereby giving rise to a higher chance of urinary tract infection. Hormonal usage, especially if they are having anti-estrogens, they can have dry vagina. This is classically seen in the post-breast CA treatment in patients and after menopause. There are certain triggers which we need to ask for recurrent UTI. Does it happen in and around menstruation? Does it happen post-coital? Have you been using steroids? Have you been on any immunosuppressants? This because menstruation and post-coital happen because of the alteration in vaginal pH. Vaginal pH is normally acidic, making sure the lactose fermenting bacteria thrive, and that offers a good support and defense mechanism to the vagina and the urothelium. When that is not, or when it is breached by menstrual decline of hormones or a post-coital where there can be an introduction of semen, which is an alkaline pH, these things get disturbed, and that could trigger off a UTI due to the breakdown of the barrier layer or breakdown of the defense mechanism, predisposing the bacteria to greater adherence to the urothelium. So I generally use a mnemonic of Berner for a proper clinical examination in any patient presenting to me for a urogyne opinion as far as recurrent UTI is concerned. As I mentioned earlier, I do a thorough vaginal examination, external genitalia examination and palpation, especially with reference to the perineal length, perineal body, any sphincter difficulty in contraction, sphincter tone, and sphincter presence. Rectal examination, abdominal examination for any mass, and neurological examination for features of any cognitive dysfunction, any memory loss, any mobility issues, stroke, and Parkinson's. So when a patient enters, I look at their gait, I look at how mobile they are. I always view their sitting posture. Somebody with a bladder pain syndrome will not be able to sit comfortably. They will be sitting at the edge of the seat. It might not be UTI, it might be chronic pain. When I examine them, I look for vulval atrophy, excoriation, contamination, any intertrigo, hygiene issues, and dermatosis. Vaginal suppleness, atrophy, any prolapse, widening of the genital hiatus, again, that can predispose to contamination. I do look for prolapse in each and every compartment, namely the anterior compartment, the apical compartment, and the posterior compartment of the vagina. I palpate the urethra and the bladder base, including the Skene's glands, because if that was to exude pus into the urethra, that could be because of Skene's gland inflammation. If I press the urethra, there is pus, it could be urethritis. Or if there is a swelling under the urethra and I press and there can be pus, that could mean a urethral diverticulum, the reason for both incontinence and recurrent urinary tract infection. I always examine for Oxford grading of pelvic muscle tone and strength, presence of incontinence, anal tone and reflexes, and a thorough neurological evaluation, including the sensory pattern for S2, S3, S4 in the saddle area, and for piriformis passage. So to make a diagnosis of recurrent UTI, clinicians must document positive urine cultures associated with prior symptomatic episodes. Always, when you're dealing with somebody with recurrent symptoms, beware they could be interstitial cystitis or bladder pain syndrome, where there will not be any pus in the urine, or this could be only minimal. OAB, overactive bladder, this will not have pain. Genitourinary syndrome of menopause, they might have frequency, they might have dryness, but it is present all the time. The dysuria is mainly related to the vagina being burning rather than the urethral pain. Urinary calculi, they usually have blood in urine or excruciating pain in the loin. Infectious bacterial or fungal vaginitis, vulvar dermatitis. Here the main problem will be pruritus. Non-infectious vulvovestibulitis and vulvodynia, these patients will always have dyspareunia. Hypertonic pelvic floor muscle dysfunction, these patients will present with constipation and difficulty in emptying the bladder, and thereby, as a result of that, can have recurrent UTI problems. Carcinoma in situ of the bladder, they invariably will have microscopic hematuria or refractory lower urinary tract symptoms, which have otherwise been treated as UTI all the time. This particular patient is a strong candidate for immediate cystoscopy, especially if she is a tobacco user or is a wife or a spouse of a smoker, because tobacco increases the chance, including passive smoking, for the occurrence of carcinoma in situ of the bladder and frank transitional cell carcinoma. So, takeaway tip: clinicians should obtain repeat urine studies when an initial urine specimen is suspect for contamination. Consideration for even obtaining a catheterized specimen. See, it's very difficult to tell our women how to catch a midstream sterile specimen of urine. They have to first make sure they wash the area just with water, separate the labia, discard whatever urine comes first into the loo, catch hold of the midstream, and also discard the end part of the urine into the loo. It is very, very difficult, especially in younger people or very elderly people who are on diapers, because they will have urgency, they will have contamination, they will have mobility issues. Patients with tremors cannot do it properly. Sometimes we need to resort to even a clean, sterile catheterized specimen as a way to find out if the culture is positive. Clinicians should obtain urine analysis always, urine culture and sensitivity with each symptomatic acute cystitis episode prior to treatment in patients with recurrent UTIs. Especially important, a complete urine routine and microscopy. The leukocyte esterase, the nitrites, the blood and urine, the level of pus cells, the level of RBCs tell us not more than what we can determine. Leukocyte esterase is because of the esterase released from the pus cells. Nitrites is nitrate reducing bacteria. There are two types of bacteria where they have fermenters and non-fermenters. So we can learn a lot just by looking at the routine and the microscopy. And without it, a simple bacterial growth will not make any sense. And that can be asymptomatic bacteriuria as well. Some selected patients, we might offer patient-initiated self-start treatment to certain cohort of patients with acute episodes while awaiting urine culture, especially premenopausal women who start post-coital UTI. You can tell them to take a nitrous-urine post-UTI, post-coital. They develop symptoms for 3 days and then see how they get on. So, clinicians should omit surveillance urine testing, including urine culture, if you think your patient has responded fully after treatment. Then no need to repeat urine routine and culture. That is not recommended as a test of cure. This is a common thing which many GPs, many people do, including patients themselves. I had taken antibiotic. I wanted to check whether I have been cured. Some 20,000 bacteria will be there. They will again take the antibiotic. That will cause significant multi-drug resistance bacteria in the community. Already a burden of beta-lactamase resistant bacteria is to the order of 85% in the community. That's a huge number. So we will not be left with much of a choice for antibiotics if we keep treating every single count growth without judicious use of the testing in the first place. Clinicians should not treat asymptomatic bacteriuria in patients. The only indication of treatment of asymptomatic bacteriuria in patients is pregnancy. So clinicians should use first-line therapy. There are only 3 reliable first-line medications in the form of nitrofurantoin or age-old trimethoprim sulfa combination if they are not sulfa allergic, fosfomycin, dependent on the local antibiogram for the treatment of symptomatic UTI in women. So this is just to give you a comparison of how effectively it works. The TMP sulfamethoxazole is a very difficult combination because of significant proportion of a patient recollecting by history, though they might not be, that sulfa allergy is a common issue. Fosfomycin is a single dose, so ensures compliance, make sure there is full eradication both for ESBL producing bacteria, Klebsiella and E. coli. When do you have to think of IV antibiotics or parenteral antibiotics? In patients with recurrent UTI experiencing acute cystitis episodes with urine culture resistant to oral antibiotics, you then can treat them with IV antibiotics for a short course is reasonable, generally no longer than 7 days. When do we need to put them on prophylactic choices? Sometimes when the patient has a cystocele which is not suitable for surgery or doesn't need surgery, but some amount of post-void residue is there, but you're not sure and the patient has recurrent UTI. But diabetes is still not come under control. Mobility is a major issue. These things we can consider prophylactic choices. And these are the usual prophylactic choices. If you're giving fosfomycin, it's 3 grams every 10 days. I do not prefer to give nitrofurantoin for prophylaxis for more than 3 months or even for 3 months in elderly patients above 65 or patients who have had chemotherapy or patients post-COVID recovery or interstitial lung disease, because nitrofurantoin given on a prolonged basis can cause hemolytic anemia, can cause interstitial lung disease and pulmonary fibrosis. So I do not recommend that in these select patients. So usually we give it 3 to 6 months and can even recycle these antibiotics as appropriately. The one candidate who will fit into this picture is somebody who's pregnant and has had a bad UTI. We do not want them to get any more UTI in this pregnancy because UTI can cause IUGR, UTI can cause low birth weight, UTI can cause preterm labor, UTI can be the cause of kidney scarring and subsequent chronic hypertension. UTI can cause even anemia in the mother. So we keep recycling them with cefalexin initially the first trimester, then go to nitrofurantoin in the second trimester, and maybe fosfomycin in the third trimester. Generally avoid nitrofurantoin in the third trimester, especially towards 36 weeks, because the baby can then have methemoglobinemia, especially in certain infants. So we tend to avoid usage of nitrofurantoin, especially towards delivery and breastfeeding time. Post-coital, a single dose of nitrofurantoin, 100 milligram, or a cefalexin of 3 or 500 milligram, and a Bactrim DS will do the trick. Other prophylactic measures. We know from recent studies that bacteria tend to produce what we call a biofilm. The biofilm acts as a barrier for these medications to act and thereby causes increased resistance to the bacteria. Now, cranberry and D-mannose prevent the biofilm being attaching themselves to the urethrium and thereby improve the chances of getting rid of the bacteria and also prevent catching of infection, especially the D-mannose. There is no strong evidence for routine probiotics, but lack of probiotics have been shown to cause UTI, whereas there is no strong evidence to suggest that prescription of probiotics tends to improve the chances of not having the UTI. Increase the fluid intake at least by about half a liter if they are already taking 1.5 liters. There is no evidence whatsoever for betadine washes, herbal medicines, biofeedback, or immunotherapy. In the European countries, UTI vaccine is now strongly being explored, especially considering the resistance patterns and the biofilm. Estrogen vaginal cream is very good. We do not treat it with systemic estrogen. Systemic estrogen is not useful, if not detrimental, for majority of the gynecologic process. 17V estradiol, 2 grams daily for 2 weeks, and then 1 gram 2 to 3 times per week. Or if you're using a conjugate equine estrogen, it's 0.5 daily for 2 weeks and then twice weekly. Clinicians should not perform a post-treatment test of cure or urine culture in asymptomatic patients. If, however, the patient has got symptoms, do repeat the urine cultures to guide further management when UTI symptoms persist, even following adequate dosing, adequate duration of the appropriate antibiotic. Encourage better hydration to ensure more frequent urination, as this can reduce recurrence. Encourage urge-initiated voiding and post-coital voiding. Advise sexually active women that diaphragm and spermicide use are risk factors for cystitis and discuss alternative contraception. Advise the patient to obtain and try cranberry products. Avoid if on warfarin, and especially D-mannose alone to reduce recurrence. Offer a prescription for a standby antibiotic to be taken at the first onset of symptom of UTI. For recurrent cystitis associated with sexual intercourse, offer trimethoprim 100 mg to be taken within 2 hours of intercourse, though it's an off-label usage. For postmenopausal women with risk factors such as atrophic vaginitis, consider prescribing intravaginal estrogen. Review them regularly and within 12 months. For postmenopausal women with no obvious risk factors, consider referral to a urogynecologist for further investigation, particularly if recurrent UTI is a recent problem. Always check midstream urine to confirm diagnosis and establish sensitivity during acquired acute UTI episode. If continued problems, consider renal tract ultrasound, especially if you see Proteus in the culture. Always rule out upper tract abnormality or calculi, because Proteus vulgaris is a bacteria which is associated with upper tract calculi, tumor, or cyst. And always, as an initial evaluation, a simple post-void residual volume is very, very important to detect voiding dysfunction. Now, this is much important to consider what is good or significant post-void residual volume. Post-void residual volume above 100 ml is bad, whereas 50 ml is not bad if the pre-void volume was 400. If the pre-void volume was only 100, then 50 is almost 50% of retention. This shows two things: a small bladder capacity, or possibly a patient with urgency, possibly a patient with a sensitive bladder, and inability to empty the bladder. So immediately do not jump to say this is a post-void residue. It could be related to infection. Always look at the post-void residual urine in absolute context with what the pre-void volume also was in the bladder. Anything excess of 15% of what was in the pre-void volume is a significant post-void residual urine. If menopausal and it's a new presentation in postmenopausal women, also consider for referral to cystoscopy if the symptoms are due to an intravesical lesion. That is the only way we can do it. Hematuria, even single episode, microscopic or macroscopic, is a criteria for immediate referral and a criteria for further imaging and cystoscopy in its own merit. If all normal, then consider prescribing low-dose prophylactic antibiotics for a 3 to 6 months period with review every 3 months. What about complicated recurrent UTI? Anatomical abnormality like cystocele or fistula. When there is an indwelling catheter for a long time, voiding dysfunction, especially in a diabetic patient. All the neurogenic bladders with pelvic floor dysfunction and high post-void residual urine. When there is an obstruction to the urinary tract, bladder outlet obstruction, or pregnancy, diabetes, and other post factors which predispose to recurrent UTI. When do you evaluate them for further investigation? When there is a prior urinary tract surgery or a trauma. Say somebody premenopausal used to have reflux. They continue to have infection. You need to image further. Gross hematuria after resolution of infection. Previous bladder or renal calculi. Obstructive symptoms. And when there is a poor flow in uroflowmetry or a high PVR or any urea-spitting bacteria such as Proteus, which I mentioned, to look at presence of any stones in the renal tract. So that pretty much completes whatever we wanted to discuss about recurrent UTI. I'm happy to take questions.
Thank you, madam. Thank you very much for this nice and informative presentation. So meanwhile, I received few. Just give me, ma'am, 1 minute to collect the questions. So, ma'am, my first question is, what is the role of pelvic floor exercise via electromagnetic chair like MCLA? Does it really help? What is your opinion?
Pelvic floor exercises will not help for recurrent UTI. But if the patient has prolapse, if the patient has fecal incontinence due to a probably previous third-degree tear repair, or patient has a very mild cystocele, which is the reason why they are predisposed to recurrent UTI, pelvic floor exercises help tighten the genital hiatus, improve the pelvic floor tone, and cause better emptying of the bladder and thereby prevents UTI. That is in patients with issues of genital laxity and prolapse. Generally, UTI is a problem when the pelvic floor is hypertonic and there is a pelvic floor dysfunction. Normally, women have to void by relaxing the pelvic floor. But in certain patients, pelvic floor has a tonicity and they contract the pelvic floor, thereby causing incomplete emptying. That predisposes to recurrent UTI. So they have to be taught reverse Kegel exercises. That is when biofeedback is helpful. So they do pelvic floor relaxation therapy with biofeedback as well as reverse Kegel exercises. That is the reason why we send them for not all UTIs.
Thank you, ma'am. And ma'am, is there any difference in the protocol of the treatment in case of early pregnancy, means UTI, and if it is in the late pregnancy?
Early pregnancy UTI.
Yes,
the early pregnancy UTI, we cannot give certain antibiotics. I generally don't give nitrofurantoin because of the risk which can happen. We prefer to give cephalexin. And late pregnancy, more towards delivery, we prefer not to give nitrofurantoin again because of the aforementioned risk of methemoglobinemia in the baby and difficulty in maintaining the hemoglobin after delivery because of hemolysis. So we prefer to give fosfomycin at the end of the pregnancy because it doesn't have any side effects. First trimester, though people have said that fosfomycin can be safe, we generally try to avoid fosfomycin in the first trimester. But from second trimester onwards, we have treated very effectively, especially with regards to prophylaxis as well.
And then, ma'am, as you told that
one word of caution: we do not use trimethoprim sulfa combination in pregnancy because it can suppress the bone marrow, cause folate deficiency, and significant effects on both the maternal bone marrow and predispose to some abnormalities in the baby because it's an antifolate. So we don't do that.
Okay, ma'am. And but ma'am, then what is the ideal cases? Means when can you give that nitrofurantoin in that case?
Nitrofurantoin can be easily given right from 12 weeks onwards to 34 weeks.
Okay.
So that's a very good window to occupy with nitrofurantoin. So, for example, we've had patients who they had to insert stents for a renal calculi in pregnancy and they have presented with acute UTI. We then keep them on prophylaxis. So the first trimester, we tied them over with cephalexin, then we changed them to nitrofurantoin, then Oserol once in 10 days. So they have a recycling of the antibiotics, but they kept on low dose prophylaxis throughout pregnancy. The main idea is to prevent another acute UTI, prevent another risk of preterm or IUGR. That is the main thing.
And ma'am, one thing is there any specific factors you have noticed that can contribute to the recurrent case of UTI?
Usually in the women whom I get referred to, the elderly people above 75 have issues with mobility. They have on diapers, they have cross-contamination. That is one major factor.
Yes.
Second major factor in that population or a slightly younger population, say 65 to 75, is long-standing menopause, atrophic vaginitis, or a prolapse with a post-void residue which is significant. In a much younger population will be factors related to either fibroids, which are pressing and causing dysfunctional voiding, and they can present with recurrent UTI or uncontrolled diabetes. In younger women, invariably the UTI patients are patients with hypertonic pelvic floor causing pelvic floor dysfunction and incomplete voiding, which predisposes to UTI.
And ma'am, my last question: what is your suggestion? Can with antibiotic drugs, that cranberry or arsolic acid, does these products help
Cranberry
in
with alone might not improve. Cranberry with D-mannose, especially D-mannose alone, can definitely reduce this is evidence-based and it is clinically recommended by both AUA guidelines, EAU guidelines, as well as USI guidelines as the only prophylactic measure for the prevention of UTI, which is recurrent. So
that means in case of recurrent UTI, you can prescribe D-mannose or arsolic acid and cranberry.
But you have to be very clear with your diagnosis as to whether it is recurrent UTI. Many patients who present with a triad of pain, urgency, and frequency, what we call the PUF triad, are patients with bladder pain syndrome. Cranberry will aggravate bladder pain syndrome. So it has to be noted that it is only in proven recurrent UTI that D-mannose and cranberry combinations will offer some benefit, not in patients just because they are diagnosed without actual culture.
Okay, madam, I could not find any other question. So thank you very much, ma'am, for this nice discussion and the medical session. So again, we look forward for some interesting topic with you, ma'am, in near future as well. So thank you very much, ma'am. Good day, ma'am.
Thank you.
Thank you very much, madam. Can we wind up the show, madam, with your permission?
We cannot hear you, Venkatesan.
Sorry, can we wind up the show, madam?
Yes.
Thank you, madam. Thank you.